Good evening. مساء الخير. يعني أنا الليلة مطلوب مني إني أقدم مريان، دكتورة مريان. عم تضحك مريان.
بتضحك.
أنا رح أحكي بالعربي لأنه بدي أوصل أفكاري هلا بالأول. مريان هي كانت شريكتي بالحرب يلي خضناها سوا بالحرب تاعت الفاكسين يلي خضناها سوا مع وزارة الصحة مع نقابة الصيادلة. فللحقيقة يعني قضينا وقت ما حدا يمكن يعني ما بنحصد حدا انه حدا يقدر يمرق بهيدي المرحله اللي مرقنا فيها مع مريان. طبعا مع مجموعه كبيره من زملائنا حكم الاطفال اللي كان بالشمال او ببيروت. على فكره انا بدي اقول شغله انه مريان من الشمال، مريان من
مظبوط،
طرابلس.
انت الشمال.
ايه فنحن اهل الشمال مسيطرين على الجمعيتين الليله، ما حدا بيقدر يعمل لنا شيء.
اوكي.
فانا بسلم عليكم كلكم من طرابلس الجريحه اللي بهالكام يوم الوضع عندنا مش كتير منيح. بريف بدي اقدم دكتوره مريان. مريان she's the president of the Lebanese Pediatric Society and the head of the division of pediatric critical care at AUBMC. She's going to talk about the treatment in pediatric COVID. تفضلي مريان.
Thank you زياد، شريك في المناضلة. مظبوط. I first I have, before I start my talk, so this is not going to be counted the time from my talk. I really have to acknowledge Dr. Bernard Gilbert, because I think with what we went through last year in terms of the fight for the vaccines, he was really our support and present with me and Ziad all the way through. And I cannot thank him enough for everything he has done. بعدين I have a wonderful team بيننا نحن وبين الشمال، لأنه on Thursday night 2 weeks ago I called Ziad, قلت له I feel like I want to do a webinar about COVID. By Saturday it was up and going, the program was set, the speakers had been spoken to, and everybody was very excited. So thank you all. Really, really wonderful to work with this amazing group of people. So Anna, when I was deciding on what to talk about COVID, I thought that really we are being bombarded from families and from social media about give vitamin C, give zinc, give remdesivir. Now هلا في ivermectin وفي colchicine. So I thought I would do an approach evidence-based, and we'll talk a little bit about the management of patients depending on their symptoms. So ما بعرف ليه ما عملت it's not advancing, just okay. So I will go brief introduction, talk about the treatments, and then, as I mentioned, approach to the COVID patient. So not to dwell too much, because Iman did a fantastic job in talking about this. We do have fewer cases of pediatrics than adults, but recent studies are suggesting that kids have similar viral loads in their nasopharynx, they have similar secondary infection rates than adults, and can spread the virus to others. Very quick reminder, the incubation period is about the same as adults, 2 to 14 days, with the average being 6 days. Our biggest challenge is that the signs and symptoms can mimic so many different pediatric infectious and non-infectious pathologies, من influenza, allergic rhinitis, strep pharyngitis, gastroenteritis. So the symptoms are very broad, from fever, fatigue, headache, myalgia, cough, nasal congestion, loss of taste and smell, shortness of breath, abdominal pain, and so on. Very non-specific. The most common recurrent theme is upper respiratory GI symptoms with fever. So I'm going to point out 2 to 3 studies that came out. So this one was a meta-analysis of 737 articles. Most of them were from China, but we had patients from Malaysia, Spain, Italy, and the USA. And basically what they looked at is the percentage of children. There were around 1,600 patients that were studied. So 16% of the patients were completely asymptomatic. The most common symptoms were definitely fever, and I'm going to take you back to cough. Sneezing came in a little bit second. And what's very interesting is that most of the kids had mild to moderate infection. Very few had severe infection, and 0.6, you're talking percent, had a critical disease. Same thing from France. So this study was one of the first prospective studies done in pediatrics. It was done during the lockdown. So what they did is they took all the patients that were admitted electively to a medical surgical ward for different pediatric pathologies. They had all in all 446 patients, only 438 had complete data. So 182 had suspected symptoms of COVID-19. Only 22 of them, which means 5%, had the PCR that was positive. And in 10 of the 22, the children were asymptomatic completely. But interestingly enough, what they ended up looking, they looked at the sensitivity and specificity of the different symptoms that the kids present with and the positive likelihood ratio. And dyspnea was definitely, if you had dyspnea on presentation, the likelihood ratio of having positive PCR was much higher. So was skin involvement, coming in the upper respiratory tract and diarrhea and vomiting. But what's very interesting, look at any symptom, you get a 55% chance sensitivity for any symptom and a 59% chance of sensitivity. So as we mentioned, they're very non-specific symptoms. Moving along to the Mediterranean area. So this was a study that came out very recently last month from Greece. And actually they looked at kids taken out of the lockdown. All right, and they looked at their characteristics. So there were 203 kids during February, from February to June. The statistics are interesting, and I think this is what everybody's been talking about. The source of transmission in these kids was the family in 65%. School accounted for only 2%, and Greece closed their school very recently. They kept them open for quite a long time. And interestingly enough, a study came out in JAMA this week or last week from Germany, also showing that the most of the transfer of or the contact, the source of infection came from family household members, not from schools. 54% were asymptomatic in this case. And as we mentioned before, most had mild to moderate disease, very few had on severe. But interestingly also, the viral load, 28% had high, 27% moderate, and 45% low. Another table that I thought was very interesting, the most common symptom was fever. This is the recurrent theme, so most of them have fever, followed by runny nose and cough, and the rest of the symptoms really dwindled down. Also, looking at the asymptomatic versus the symptomatic, the younger you are, the most probable that you are symptomatic, which is kind of expected. But look at what's very interesting. The viral load did not differ between whether you were asymptomatic or you were COVID positive. So this is really very interesting, and this is what most of the studies are showing. So we know that there's lack of sensitivity and specificity, and this is why the symptom-based screening can be very challenging for us pediatricians. So talking about severity of the illness, thank God kids are not developing the same severity of illness as adults, but they are still at risk for that and their complications, especially the MIS-C that Dr. Wakim is going to talk about in a few minutes. We know that hospitalizations are increasing, and over the past few months in the US, 1 in 3 children hospitalized are admitted to the PICU. So the question for us as pediatricians, are there any comorbid conditions that we have to worry, that we have to say, okay, this kid is as higher risk, we need to observe closely? So this is from the US. This is a study that they looked at for 20 states and from over a period of 6 months. And they showed at the beginning, you had 2 per 100,000 hospitalization in the pediatric population. By the end of the study in November 15, you were up to 17.2. So the numbers are increasing. And if you notice, they are also very increasing for adults at the same time, and we know that. Some of the clinical features, this comes from New York, also published the summer of last year. So what was very interesting for the severity of illness, the older you are, teenagers, so you tended to have the same pattern as adults. So you tended to be more sick. If you presented with shortness of breath, also this is recurrent, then you tended to be more sick. Also, if you had gastrointestinal tract symptoms, it tended to be. Congestion runny nose, it did not reach statistical significance, but it was there. In terms of comorbidity, the one that's really very concerning, I think, is the obesity, and it comes up in all the studies. And we do know that we have a population in Lebanon of children that is obese. So it should be definitely on our mind when we look at kids. All right, the other thing, they looked at lab values between severe and non-severe. So the 2 values that reached statistical significance were the CRP and the procalcitonin. But in terms of ferritin, interleukin-6, D-dimers, PT, and PTT, there was no significant difference between whether you had a severe illness or a non-severe illness. Another study that came out from the CDC looking at the characteristics of children less than 18 years. And interestingly here, they stratified the kids. They had 576, 0 to 2 years, 2 to 4 years, 5 to 17 years. And I'm not going to bore you with numbers, but obesity, chronic lung disease, asthma, and prematurity, gestation age less than 37 weeks seem to play a very important role as a pre-existing condition. So if I want to sum up everything that's been described in the literature, infants less than 1 year, if you have medical complex situations, genetic, neurologic, metabolic conditions, or congenital disease that puts you at higher risk. And interestingly, similar to adults, obesity, diabetes, asthma, chronic lung disease, or sickle cell disease, or immunosuppression also puts you at higher risk. Now, just as a note on the side, we have seen in the past 3 weeks an increased number of diabetic ketoacidosis, new onset diabetes. Now, we're testing them for COVID, they end up negative, but it's just the cluster is very different from last winter. So most children from different study with cancer will get COVID, but they will not develop severe COVID-19 illness. So what do we mean by severe illness? Respiratory failure requiring intubation. We're talking in the acute phase, not 3 to 4 weeks later when we're talking not about the MISC. Myocarditis, shock, acute renal failure, coagulopathy, multi-organ system failure, intussusception, and ketoacidosis like we just mentioned. So here comes the challenge, treatment. Do we give vitamin C, vitamin D, zinc? And I'm going to focus on these 2 drugs, the dexamethasone and the remdesivir, for just in terms of what is available in the literature. So why all the hype about vitamin C? Just a quick reminder, it's a water-soluble vitamin that's thought to have beneficial effects in patients with severe and critical illness. Study. It is an antioxidant and free radical scavenger that has anti-inflammatory property, influences cellular immunity and vascular integrity, and serves as a cofactor in the generation of endogenous catecholamines. So when you are in an oxidative stress, you may require more vitamin C. And it has been evaluated in several studies, including ARDS and serious infection, but the variability of the efficacy was questionable, and there were some few safety concerns. So the recommendation of the CDC and currently and the WHO, there are insufficient data to recommend either for or against use of vitamin C for the treatment of non-critically ill and critically ill patients. And I'm just going to show you a table. I took it early this week about how many studies are going on worldwide looking at the efficacy of vitamin C in treating COVID-19. So you have from Canada, you have from the US, you have from Turkey, you have from China and Saudi Arabia. So all over. Zinc, the famous zinc that's not available anymore in the market. So increased intracellular zinc, we know impaired the replication in a number of RNA viruses. We know also that it has a cytotoxicity and induces apoptosis in vitro, no in vivo studies. I'm just going to reiterate this. And the relationship between zinc and COVID-19, including how zinc deficiency affects the severity, supplement is still under investigation. No studies have been completed so far, and we don't know really if it makes a very big difference. And just keep in mind, long-term zinc supplementation can cause copper depletion, and copper depletion can have reversible hematologic effects and potentially irreversible neurologic manifestations. Okay, so the recommendations are very clear against the use of zinc supplementation above what you eat regularly, and we all recommend a healthy, well-balanced meal for all kids for the prevention of COVID, except if you're doing it through a clinical trial. فقط لا غير. Also, let me show you the number of studies that are ongoing. Some are not yet recruiting, some are recruiting. So it's all over the place about looking at zinc, among others, as a modality of treatment. Vitamin D. Our famous vitamin D. So we know it's very important for bone and mineral metabolism. It's expressed on immune cells, okay, and it activates to the vitamin D. And we know that it can modulate innate and adaptive immune responses. And also, supplements may increase the level of T regulatory cells, and it can increase the cell activity, the T regulatory cell activity. So what is also known is that vitamin deficiency is more common in older patients and with obesity and hypertension. And we know that it has been associated with worse outcome with patients with COVID-19. But, and also in pediatric and adults, there are several studies that show that low vitamin D have been associated with increased risk of community-acquired pneumonia. So what are studies available? There was, if you look at the meta-analysis of randomized control study, it was shown to protect against respiratory tract infection. But when it was given in high doses, and they're recommending 4,000 units per day, if you look at what the social media is circulating and the prescriptions that are going around, to critically ill with vitamin D deficiency, but it was not studied in COVID. did not reduce the length of the hospital stay or the mortality rate when compared to placebo. And remember, high doses of vitamin D are not without secondary side effects such as hypercalcemia and nephrocalcinosis. So again, the statement is very clear: insufficient data to recommend either for or against use of vitamin D for the prevention or treatment of COVID-19. So for me personally, I'm telling them to take the regular dose that they're supposed to take of vitamin D, especially that our kids are homebound, they're not going out, they cannot play outside. So just supplementing with the regular vitamin D, and I'll be very interested to hear what others are doing. So also many studies going on, some have completed, some are still recruiting all over the world to look at the efficacy of vitamin D for COVID-19 infection. WHO comes out with a very clear statement. There are important vitamins D and C and zinc, but there is really no guidance as a supplements for the treatment of COVID-19. We have to await the studies, which is very challenging. So in pediatrics, no drugs really approved for FDA, supportive care, antipyretics if they have fever. What about steroids and remdesivir? So remdesivir is really approved for kids above the age of 12 or above 40 kilos, but recently it was an emergency use, can be used or compassionate use for children who are less than that age. So steroids, and I'll go over that in a few minutes. The only time really to use steroids is for critically ill COVID-19 patients. So a patient who has a little bit of cough at home, not to use Decadron, whether we're talking pediatrics or adults, because I think all of us are getting questions for how to treat adults as well as pediatrics. So if there is an increased oxygen requirement or they're admitted to the hospital, then it's when you would consider it, but not for a routine patient who has COVID-19. It is really not indicated at all. So also many studies going on about dexamethasone and the treatment. And the first study were very conclusive from Wuhan that really did make a difference in the the critically ill adults who received Decadron early on in their course. Okay. So remdesivir is an IV nucleotide prodrug of an adenosine analog. It binds to the viral RNA-dependent RNA polymerase, inhibiting its replication. Okay, so as I mentioned, it's approved for above 12, but they allowed us to use it for emergency use authorization for kids who are above 3.5 kilos to less than 40 or who are weighing above 3.5 kilos. Okay, so I'm going to reiterate, and please, I think this is my most important take-home message. There is insufficient data for other antivirals or immunomodulatory agents in pediatric population. Even adults, they come up with something, a few months later, they say this is not correct at all. I think the most important thing is that we have to enroll children in clinical trials, because really, I cannot say enough that children are not young adults. So sometimes, a lot of times, you cannot extrapolate from what the adults are doing. So let me go over in the last few minutes about the spectrum of disease and the guidelines from gathering what we are doing. So if a child comes in with mild symptoms, and I mean by mild symptoms, a little bit of fever, cough, sore throat, any of those, rhinorrhea, malaise, a little bit of nausea and vomiting, but well hydrated, the child is acting fine like any other virus. Typically, if they're at home, I really don't test them, or we ask not to test them. If they come to the ER, we test them, but we don't do anything more than COVID testing in the current times. We don't admit. And usually it's symptomatic treatment, make sure that they are getting acetaminophen for the fever, and if they're in pain, if they have myalgias, and just keep on being well hydrated, but no need for admission. What about mild symptoms, but they have underlying risk factors? So any of what we mentioned about before, they're obese, they have chronic lung, heart problems, renal, hematologic, they're oncology patients. Actually, most of these patients also will not need admission, okay? They can be managed at home. If we need to admit to the inpatient unit, usually it's for IV hydration and antipyretics, because most of the time they come a little bit more dehydrated because they're having diarrhea or vomiting. They don't need anything more. Remdesivir, I ask everybody not to use it left and right, and it's only done after we consult with our pediatric infectious diseases. Prophylactic anticoagulation if the patient is at risk or they have an underlying condition because of their underlying condition. Also, this is not done except with consultation with our pediatric hematologist oncologist. What we monitor for is make sure they're well hydrated, their respiratory status is fine. Usually it's a 24 to 48 hour admission, and then they can go home. Just some guidelines for whenever you admit patients, if you're going to admit patients to your hospital. What we stress, it's only one adult that will stay with the child, and we assume that the adult is in isolation while in the hospital premises. And I think all hospitals are doing the same thing. We avoid the use of any particle generating procedure, especially the nebulizer. So we tend to use meter dose inhaler if we need to give bronchodilators or inhaled steroids. And our infectious diseases team recommend for patients who are going to get admitted. I'm not saying all of them need all of this, especially if it's mild, you might not need to do all these tests, but this is the panel that you have to keep in mind. So looking at the CBC chemistry panel to make sure they're not very dehydrated, LDH, CRP, and procalcitonin, because as we said, these tend to be much higher in the severe cases. Liver function test, ferritin, CPK, troponin, looking at your coagulation profile, blood group, and then really, depending on the age, the blood culture or how sick they look. Chest X-ray, if no respiratory symptoms, I would not go expose them to any radiation. EKG, if there are any symptoms. Remember, and Dr. Iman mentioned it very nicely, even if they might be RSV or influenza positive, so we cannot omit that these are the winter season viruses and we have to look for them. CT scan, I urge you not to do it if there are no respiratory symptoms. And the American College of Radiology was very clear that it should not be used as a first-time test to diagnose COVID-19. I know a lot of hospitals, every patient who comes in for COVID for adults gets a CT scan automatically. We have to shy away from doing that in pediatrics, and they did recommend doing a chest X-ray unless really you have some big concerns about the patient, and then it becomes a different story, but it should not be in the routine recommendations. So moderate symptoms would be when a child has lower respiratory tract infection without new oxygen requirement, or if he's already on oxygen, has a little bit of increase in oxygen requirement. So not a severe pneumonia, but has cough, difficulty breathing, he's tachypneic, or has evidence of pneumonia on chest X-ray. So it's a lower respiratory tract. Also, we admit for monitoring of the respiratory status, it is IV hydration, antipyretics, same as before. The decision to give remdesivir is made really if they are severely immunocompromised of the cardiac or pulmonary disease and they are obese. So also consultation with our PEDS ID. And anticoagulation, we have to consult our hematologist to assess the risk for thromboembolism, but not everybody who gets admitted gets it automatically. All right, if we think that they have a community-acquired pneumonia, definitely ceftriaxone is recommended. And if they're immunocompromised, then you might have to broaden the antibiotics. We monitor for vital signs and respiratory status. So the labs, how often do we repeat them? If they come in and the labs really are not that bad, I tend not to repeat them or repeat them before discharge at 48 hours. But if I have any abnormalities, we tend to trend them every 24 to 48 hours. All right. Last is the red flag. So the severe symptoms, so they have lower respiratory tract infection, a pneumonia with new oxygen requirement, or so they have three things that we worry about. Their SATs are less than 90% on room air. They have severe respiratory distress, they're grunting, they have severe distractions, or they have signs of the pneumonia with inability to breastfeed, lethargy, they come in altered level of consciousness and convulsions. Remember, this is done on clinical grounds. You can look at the child and you know that he needs admission. You might want to do a chest X-ray. I still am going to say CT is left really for the very challenging cases, or if you're really concerned about something else, but sometimes pleural effusions can show up and a chest X-ray would be a must here. So we admit usually for a few hours to the inpatient unit because the patient is going to declare themselves. Sometimes they're a little bit dehydrated. With IV hydration, you notice that they're settling down with a little bit of oxygen, their symptoms become better before we make the decision whether they need a PICU or not. So typically we give low flow nasal cannula up to 3 liters per minute. We aim for SATs above 90%. They do get remdesivir and they do get dexamethasone or alternate therapy. Also remember, these two will with consultation with our PEDS ID, anticoagulation after consulting with hematology. As before, if you're worried about community-acquired pneumonia, then IV ceftriaxone. They are monitored very closely, and all of these patients who get admitted, their labs are abnormal, so we need to trend them every 24 hours. So our criteria for PICU admission is that you're going up on the oxygen by nasal cannula or face mask and unable to really maintain the saturation. Even if you put in under-breathing, the SATs are still low. If they need intubation or vasopressors, they get admitted to the ICU very quickly. All right. So very quickly, I'm not bore you with the last few slides. So the remdesivir, as you mentioned, it can be used on emergency basis. But remember, you have exclusion criteria for the use of remdesivir: multi-organ failure, vasopressor, if you have liver functions that are abnormal, kidney function that are normal, or if for any reason you're taking other viral agents. Enoxaparin, we consult our hematologist. And steroids. The recommendation is by far dexamethasone, but as you know, it is not available a lot of times. So the alternative, you can use prednisolone 1 milligram per kilo, or methylprednisolone 0.8 milligram per kilo once a day, or hydrocortisone 0.5 milligram per kilo every 12 hours for 7 days. So it is definitely, there are alternatives. So in conclusion, and I'm going to shy away from talking about the severity of illness, I think if we look at what our children are going through, it will be interesting what they're going to tell their kids about growing up during the COVID-19. I think the infants, by the time they grow, the vaccine will be out, they will probably not remember it at all. Toddlers, maybe, okay, I was at home with mom and dad. I think the older children, the teenagers, know that they're missing on milestones. So many kids could not graduate from high school last year, did not have their graduation, or from college, so they are going to remember it. And luckily, most will not recount that they were ill with the disease, okay? Although we still have some who are going to go on to develop a complication. But my biggest concern is the effects of this pandemic will reflect on their education and psychological well-being. And it has been very well shown that when parents are financially and psychologically stressed, there's a change in the cortisol regulation and brain structure and function in children. And I challenge anyone to tell me which parent is not financially and psychologically stressed in Lebanon. So how it's going to show in kids is going to come in the years to come. So many children, and we cannot forget about it, would have lost a close relative to COVID. And I challenge, do you think distance learning is effective learning? I have big doubts about it. And it has been shown in many studies, if by grade 1 you don't know how to read, it will impact how you graduate from high school. And it will be interesting to see how they perform in college. As pediatricians, we always have the challenge of limiting digital time with the kids. Right now, kids are spending 8 to 10 hours doing their classrooms on WebEx and Zoom, and then doing their homework. So how do you reconcile with that? School children in Wuhan during the lockdown had increased depression and anxiety. How long did the depression last? What are the sequelae? I think the effect is in the years to come. And I think this is going to be our platform for our next webinar, looking at the mental health well-being of children during the lockdown and during the COVID. Thank you very much.
Thank you, Marianne. Very informative talk. For the question, for the question, Marianne, do you أنت تسمعيني Marianne?
أنا معك. I am not.
Dr. Farah Lais asked a question, should we delay vaccination after COVID infection?
After the kids get COVID, I think one of the big challenges, and I think this is going to be also one of the topics we're going to discuss in our next webinar, what happens with the vaccination.
Yes.
When I asked our infectious diseases person, and since we have two with us on board right now, Dr. Rima and Dr. Iman, I don't think we need, during the acute phase, we're not going to see the kids anyhow because in quarantine. But I think once they are well healed, or the confinement is gone, they have to go back and get. I think the vaccination is going to be essential for us not to miss on our kids, because we don't want to see the resurgence of other diseases because kids are missing on their primary vaccines.
Okay, not all the questions. All the questions are related to the treatment. Okay.
I know, but I just want to answer the two things. The ivermectin and the colchicine, there are no data in pediatrics whatsoever so far. So we know a lot of our patients are on colchicine because for FMF. It will be interesting to see if they will go on to develop a more severe illness or any illness, but no data whatsoever on the in pediatrics.
Yeah, Dr. Hayat, what type of mask should children wear during COVID-19 pandemic?
I think the masks, it was also established by the Ministry of Education. They have to wear the cloth mask. So less than 2 years, I think less than 6 years, they're not wearing, but except if they're going outside in public, in school, in bus transportation. But it has to be the cloth, sorry, it's surgical masks. I think new data is coming up about the cloth mask being not efficient as the surgical mask. I'm sorry.
Yeah, Dr. Ashkidi asked you about Lebanese publication concerning pediatric COVID-19, not related to treatment.
There are no publications yet of pediatrics. Dr. Ziad and I were talking, and I think I launched it on the group. And right now we are talking with the Ministry of Public Health for the Lebanese pediatric societies, both Beirut and North, to take ownership of the COVID-19 in pediatrics and to look at all the complications and start coming up with more concrete data and to be able to do some publications.
Yeah, Dr. Edgar Asmar, when we say pediatric asthma is high risk factor for COVID-19 severity, we usually mean uncontrolled severe asthma, or do you have other data?
No, Dr. Asmar, you're absolutely right. It is usually in the uncontrolled or the poorly compliant patients. But the mild asthma or well-controlled, we did not have, or even in our experience at the UBMC, we did not see sicker patients because of this. But you're absolutely right.
Dr. Shibel Mourani, hi, Dr. Shibel, اشتقنا لك. What are the percentage of severe cases similar to Kawasaki diseases admitted to ICU in Lebanon and comorbidity? طبعا هذا موضوع.
Dr. Rima Hanna Wakim is going to answer that question in her next talk, if you don't mind.
Yes. Dr. Hayat, should we children with asthma wear mask during COVID pandemic?
I think the same guidelines apply for all children.
Yeah.
Absolutely.
Dr. Abir Buhamdan, it's safe to give ibuprofen to COVID patients?
Look, Abir, I have been doing it when they have very high grade fever, and sometimes you have to do it. And you know, the studies that came out initially about ibuprofen making it worse have been refuted. So I am.
دكتور ماريا كرم عم تحكي عن ستادي صارت بفرنسا من شهر وبيعطوا 200 to 400,000 unit of vitamin D to adult COVID patients. في data عن بالpediatrics?
Maria, this is what I mentioned. We cannot extrapolate from adults because even the adults, if you look at their studies, a lot of them, there were some concerns about it. So Anna, as I said, and I hope everybody's doing the same, I'm telling them go for the regular dose of vitamin D that you should be taking anyhow, especially that our kids are not seeing this.
Marianne.
Hey. Hello.
عم يروح الصوت مريم.
Sorry, Maria, I will not extrapolate from adults yet. I'm going for the regular vitamin D for 100 units, and I would like to hear what others are doing.
دكتور جوليان طيف بتصور هذا نفس السؤال نون ستيرويدال جاوبنا عليه. دكتور ربيع شكرون, if there is an advantage of dexamethasone compared to prednisone?
Look, hi, Dr. Shakarun. The dexamethasone as an anti-inflammatory, it's just, it's more potent, but there are a lot of countries when they don't have it. So this is why I wrote the equivalence of prednisone and so on. So we have been using it interchangeably when dexamethasone is not available, especially if you want to send. I had a teenager with a bad bad pneumonia from COVID-19, and I could not find the dexamethasone. I ended up sending her on prednisone, and she did very well.
دكتورة زينة أبو جمرة بتصور كمان ردينا على هذا الأنتي إنفلاماتوري والهذا. دكتور عماد شامي, هاي دكتور عماد. Can we comment about ivermectin? أنت مريم ما في studies.
I said there are no studies, but as I have two experts on the panel, I will, if we have time, I will ask Dr. Rima Hanna Wakim to answer that.
دكتور زخيا صليبة. What about COVID and congenital heart disease? Is there any specific recommendation?
Hi, Zakia. Nothing different than just being more, what do we say, vigilant in case they develop the COVID. Yani they need a more closer follow-up because of their underlying disease, they're a little bit at higher risk. Okay, but a congenital heart disease that is completely repaired and the kids are doing fine, they are the same risk as the population. It's the ones you worry about who have still a cyanotic heart disease, who have conduits, who are undergoing still some surgeries. But the repaired surgeries, there has not been an increase in the numbers or severity.
دكتور نمر غرزدين.
Reduction in the influenza.
Yeah. Have you noticed a reduction in influenza infection during the pandemic COVID?
We have actually, and I think لأن الأولاد قاعدين بالبيت ما بيلقطوا شيء. نحن لهلا I'm trying to think. ما بفتكر ريما صلحي لي ما شفنا ولا انفلونزا لهلا ما هيك؟ I don't think
wearing masks كمان يعني الماسك كان كثير عم يخفف.
ما عم بيروحوا على المدرسة.
What you do in ER for a child with wheezing need the nebulizer and we don't know if he is positive or not.
Not via meter dosed inhaler. We don't use the nebulizers. We're not doing it. أو بنحط spacer if we need to do that.
Dr. Diana Karkar, if there is any relation between the severity of COVID and the use of non-steroidal in children, احكينا فيها بصور.
ما في. Hi Miriam.
Okay. ميريام دكتور ميريام. Your experience was positive newborn. هلا رح نحكي عنها بتصور بعدين. غيث رح يحكي عنها. ما بعرف قديش بعد معنا وقت. بتصور مريان.
لأنه أنا let's move on to the next talk.
Yeah, okay.